Hello, everyone, and welcome to another episode of Transforming Relationships. I'm here with my co-host and friend, Dr. Eric Spiegel. Good morning, Eric.
Good morning, David. So good to see you.
Well, today, folks, we are going to be interviewing Dr. Michael Osterholm. He is formerly the state epidemiologist in Minnesota. He is currently at the University of Minnesota, where he continues to do cutting-edge research into pandemic risk, viral risk, risks to public health, putting that information out there. And in our conversation with him, I'm hoping that we can really get into a discussion of what it means to be in a position of caring for the public, of wanting to preserve and promote everyone's health, and a little bit about what in the world went wrong during the COVID period, where trust in public health officials, trust in medical expertise really seemed to crash and pitted people against one another in ways that I think continue to reverberate throughout the country. So I'm really looking forward to hearing what Dr. Osterholm has to say about those threats to a shared truth about something as intimately important as our own health and well-being.
David, what I loved about what you just said there in the introduction was you found a way to kind of integrate the public health aspect, the epidemiological aspect, this incredible area of expertise that Dr. Osterholm has, with, the focus of our show, which is relationship and how relationships facilitate trust, how they facilitate division, how we can come together, internally, interpersonally, collectively, or we can be divided.
Yeah.
And so he's going to be such an interesting perspective, both in terms of offering his thoughts about, essentially what went wrong during the COVID pandemic and maybe helping us get back to a way of what could go right.
I hope he will give us some information about exactly that. The Lord knows we have a path to healing that we're on, and so far I don't see the end of that path as immediately accessible, reachable. So, looking forward to our discussion with Dr. Michael Osterholm. Good morning, everybody, and welcome. Welcome to Transforming Relationships, the podcast that I co-host with my ever-present colleague, Dr. Eric Spiegel. I'm in Minnesota. Eric is either in Maryland or in Pennsylvania because he goes back and forth between the two. And today we have a very, very special guest. It's Dr. Michael Osterholm, also here in Minnesota, but known, frankly, around the world, and known both for the work he's done over the years with, he's an epidemiologist, the work that he has done around all sorts of foodborne and airborne and other vectors that allow pandemics to take hold and spread, other illnesses to take hold and spread, and we may find that you know him most around the work that he did during the years that COVID was ravaging not just this country, but the world. So we're here today to talk with Dr. Osterholm about epidemiology and about the way epidemiology intersects with Eric's and my passion, which is what are the different types of relationships that bind us together in ways that are positively transformative, that make us a larger and healthier community, and what have we seen over the last few years that frankly work in the opposite direction. So let me tell you a little bit about our guest today, Dr. Michael Osterholm. He is, as I said, a renowned epidemiologist. He was kind enough and humble enough to say he's been in the field for 51 years, although looking at him, you would never guess that. So good for you, Mike, for maintaining your youthfulness. He is currently at the University of Minnesota in what's called the Center for Infectious Disease Research and Policy, or CIDRAP. He is also involved with another program at the university, frankly, many programs at the university that work on building consensus, doing research, integrating and synthesizing different sorts of information that ultimately work to keep us all safe, keep us all informed, and keep us all healthy. Mike, is there anything that you want to add to make sure that our audience knows about what your current passions and activities are?
No, I think to give them some sense of my perspective, I might add that, I've now, as you noted, been in the business for 51 years. During that time, all of those years were spent at the University of Minnesota. But in addition, for 25 of the years, I also split time between the Minnesota Department of Health, where I was the head of the infectious disease group there, and also state epidemiologist. And so I kind of was able to have one part of my life with my head in the clouds, the other part of my life with my feet firmly planted in the soil. And I think that was helpful. In addition to that, I've had a role in every presidential administration dating back to Ronald Reagan, where I was involved with HIV/AIDS and the AIDS Commission. Even during Trump 1, I served as a science envoy for the State Department, traveling around the world in 2017 and 18, trying to get the world ready for another pandemic, which no one believed was ever coming, which then did come. I was on the Biden-Harris transition team on COVID. And I think the message that's really important to understand is that during that time, I served 2 Republican governors, 2 Democratic governors, and as we affectionately say in Minnesota, 1 wrestler governor during that time. And no one could tell you my partisan politics if I had any. I've just been a private in the public health army. My job is to do my job, is to call balls and strikes as I see them. And so today, my comments, please take as such. I have no political affiliation with any one group. As I said, I've worked through all those different administrations. I'm here today just to share what 51 years worth of experience have brought me.
So what you just said seems like a perfect segue into taking our conversation further. In your most recent book, I think it's your most recent book, the big one, is that the most recent one?
Right, that was published in September. I had 2 previous books that were published, Living Terrors, What America Needs to Know to Survive the Coming Bioterrorist Catastrophe, which was published on 9/11 of 2000. I think I bought 14 of the 18 copies sold that first year. And then with the advent of 9/11, it became a New York Times bestseller. The same thing happened in 2017. I published a book, Deadliest Enemy, Our War Against Killer Germs, in which I laid out a lot of what a pandemic would look like, kind of predicted the 3 to 4 year course of it, etc. And that book did okay, but then, of course, when the pandemic hit, it became a New York Times bestseller. I think the goal I have right now is to make sure the big one does not become a New York Times bestseller, because that means we'll have failed miserably. And that one is all about the lessons we should have and could have learned from COVID, but have not. And that leaves us still very unprepared for the future.
Well, I have heard it said in the military world that armies in war are always fighting the last war. And it seems as if one of the things I took away in reading your book is that, these little microorganisms, they do not spend any time making sure that you are a Republican or a Democrat or a Muslim or a Jew or a Christian or whatever. They look at you as having the goods that they want and need in order for them to be here. So in a sense, they're the most democratic organism out there. They don't care about your affiliation. They just care what you're made out of.
Well, let me add an addendum to that, okay?
Please. Yeah.
The one thing that they do is they tend to pick on the weakest of it. Okay. And what I mean by that is if you look at, for many infectious diseases, the people who are most adversely impacted are those who are very young, those who are very old, those who have underlying immune conditions that put them at risk. And so while an infectious disease may cover the entire population, some parts of that population may get hit a lot harder than others. And it tends to be always the weaker of us that happens with.
Right. Well, on that point, as a psychologist, Eric, I'd be curious what your thoughts are here. The weaker among us can mean lots of different things, right? Weaker in terms of our ability to trust good information, as opposed to being swayed by someone who's trying to peddle things that divide us. And I think we've certainly seen that. And I'm really hoping as we talk today, what is the underlying strength we can evoke in how epidemiological public health information is disseminated that organizes us around what makes us stronger together rather than what enables the weaknesses we carry to divide us and pit us against one another. So we can talk about that more unless you have a comment on that point right now. Any?
Yeah, well, I think an important point to understand here when I talk about the weakest, I'm talking about those whose immune systems are not necessarily in the same place that someone else's might be in terms of the level of protection it can afford. Also, remember, we have a population that has many underlying health conditions, obesity, diabetes, all the kinds of things that can cause you to be much sicker when you get infected with the same virus as somebody who's otherwise healthier wouldn't be that sick. The other thing that happens, of course, is that today, as one of the benefits of modern medical care, we have a lot of people who are living who are really, you might say, on new borrowed time, meaning that they have been infected with a particular infectious agent 20 or 40 years ago, they would have died from that. But because we now are able to keep people who have, for example, transplants, who have any number of different conditions that put them at a higher risk for not having the same level of immunity response. And so today we're seeing that. We're seeing people who are now really at risk for these infectious diseases because they're living with basically an impaired or reduced immune response capability. But that's also the reason why they're still alive.
Yes. Yeah.
On that note, I'm curious about something, and obviously I do not have the pedigree that you do, but one observation that I noticed during the COVID pandemic was that, all of the significant mutations happened in these immunocompromised people. And I wonder if you could just speak to our audience about what that process was and what we might learn from it when we think about working to prevent the spread of the next pandemic.
Well, first of all, it's important to note that, a virus like the COVID virus basically can kill you, whether you're healthy, young, capable, or not. It's a frequency at which it has the negative impact. We know, for example, what we call the case fatality rate, or the frequency at which when someone gets infected, how often do they die from it, is much, much higher in those over age 50 to 60 than those who are younger. But it's also much higher in those under age 1 to 2 years of age. And so you kind of get this bimodal curve of severe illness. One of the things that you raised is the virus changing, mutating over time. And every time it passes through another person, that gives it one more opportunity to grow, to go through mutational changes as it grows up into, you might call, the adult form of the virus. And so really what we're concerned about is anytime they're spread, you're going to have more mutations. Now, some infectious agents are much more likely to mutate than others. Some, for example, like the measles virus, has mutated very little in many, many decades. And so that's why vaccines today that are the same ones that were used 40 years ago still have pretty darn good protection. A virus like SARS-CoV-2, the cause of COVID, actually may mutate frequently in anyone who's infected. And that's why we saw during the COVID pandemic these different waves of infections where, in a sense, people are kind of seeing a new virus almost throughout the pandemic from time to time, because of what now was floating around in the population wasn't necessarily the same type, or at least the same virus that was floating around 2 years before.
Mm-hmm. Well, you make the point in the big one that we have a chance, human beings have a chance to mutate roughly once every generation, or about every 25 years, whereas certain viruses or other microorganisms are mutating, every 20 minutes. Yes. So it's a competitive disadvantage, which I think, if I remember right, was something like 16 plus million to 1. Something like that.
I can't say we have a number for that. I can just tell you that, again, it depends on the infectious agent. Some infectious agents are much more stable, as I mentioned, with measles. Mm-hmm. On the other hand, if you look at agents like COVID, you look at influenza, you can see a virus that may change substantially every couple of months. And so it really depends on which infectious disease you're talking about. And the ones that are most at risk for pandemic transmission, meaning that they cause a worldwide outbreak, are those that, number one, have significant changes in what they look like, meaning major mutational changes, so that in a sense our bodies don't recognize it as having seen it before. And so just because you survived 2 years ago, developed immunity to that virus, doesn't mean you have the same level of immunity to the virus you encounter today. The second thing I think that's very important, as I noted, is some viruses just are much more stable. And so you're really dealing with the same virus. When you look at the smallpox virus, something that an infectious disease we eradicated in the late 1970s, that virus likely changed very little over many centuries, whereas some viruses like the flu or COVID viruses could change substantially in a couple of weeks. So that's one of the things that we look at carefully about determining what are the highest risk viruses that we worry about for causing a pandemic. One, they're transmitted via air, meaning that just breathing air is enough to get infected. You don't have to touch people. You don't have to have intimate contact. You don't need to inject anything or have a bite. You just have to breathe in the room. And that's a very important point also for determining what is likely to become a pandemic virus.
So I think that from Eric's and my perspective, one of the things that we have been most struck by is human beings tend to, like the saying goes, circle the wagons to join together when they feel they're under attack. Okay? Here, in the world of epidemiology and microbiology, what we saw over the last 5-7 years is the antithesis of circling the wagons. Right? That old biblical saying, am I my brother's keeper? We weren't. Right? We were arguing against each other. So
before you go on, let me add a perspective to that might be, I think, helpful. We did circle the wagons. The problem was we circled them into blue wagons and red wagons.
Yes.
And we shot at each other as much as we shot at the virus.
Yes.
And so it wasn't a disorganized situation. If you look at the red states and look at how many people rejected the vaccines that were available that could save their lives, and how many hundreds and hundreds of thousands of people that died in those states needlessly because they refused to get vaccinated. That was a group that had circled the wagon, but they did it in a very unfortunate way. And so I think that was one of the challenges we had, is we don't know how to break from one wagon train circle to the other today to help, basically provide the kind of information that people can evaluate on their own and decide, wow, I want that vaccine.
I'm wondering, I want to circle back to something you said at the beginning to add to what you just said there, Michael. You mentioned that when you talked about your 51 years of work in this career, that you could describe one part of it as being boots on the ground in public health department, and then one side in the research and in the public interest in your work at the University of Minnesota. So I'm struck when we circle the wagons in different ways, in blue state ways and in red state ways. How can public health departments, public servants working in these departments who have the greater good in mind, adapt to those two realities with, and I may be wrong about this, but with the expectation that perhaps some of those dynamics may still be in play the next time we're dealing with a virus that's a pandemic potential?
I think, Eric, if I could answer that question for you, I would deserve a Nobel Prize. And I'm not ever going to say that to anybody, that I think I deserve a Nobel Prize. And it's because of the fact that we're in a whole new era of information sharing and information understanding. For example, I do a podcast. Just completed our 200th edition of it over the course since 2020. And it's by all regards been successful in the number of listeners. But I jokingly say the average age of the listeners is about 97. Okay? And that doesn't help us deal with the young expectant parent who is anticipating getting their child vaccinated at birth, but feeling very, very concerned about the safety and effectiveness of vaccines because of all the misinformation. How do we reach that individual? How do we reach the 18 or the 20 or the 25-year-old? And we don't know how to do that today. This is an era of information dissemination unlike anything in history, okay? I mean, even back in the Middle Ages, the Gutenberg press didn't give people the sense of, wow, look at all this information now. We live in a world that is saturated with information. But the problem is a lot of it is disinformation or misinformation. It's not correct. It's not honest. Some of it's not by intent, but it's just become a prevailing belief. And so we have a lot of work to do, Our center is actually focusing on that very issue, is how do we share information? And we've already come up with some interesting conclusions that say that when you're talking to young expected parents, there may be very, very different reasons why they do or don't get their kids vaccinated. They live in a community or have family members who have had vaccine-related infections that killed the child. That leaves a big impression. On the other hand, they may have individuals who believe that they were injured by the vaccine, and they make claims to that effect. And so now, as a parent, you're wondering, oh man, am I going to expose my child to something that if I don't vaccinate them, they won't then get exposed to that bad thing, without really understanding what the benefits are of being vaccinated. And so your question's right on the mark. It's a really important one, and it's one that we're ill-prepared to deal with right now. And I have to say, we're getting beat hands down with the mis and disinformation versus the factual information. You know, a lie can travel around the world multiple times before truth has a chance to get out of bed. And I think that that's one of the challenges that we have right now.
Well, ironically, do you want to go ahead, Eric? I think we're in the same movement.
If I may, just a quick response.
Yeah.
You know, our last guest was Renee DeResta, who's a professor and researcher at Georgetown into social media misinformation and exactly the kind of human dynamics. And one of the things she was talking about was that the dissemination systems happen more quickly and they leverage people who seemingly are, you know, trustworthy, but as we understand, they may be influencers with little kind of actual expertise. What I was struck by from that interview, and I'm wondering to ask it to you here, is when I was listening to you there, it sounded like part of the challenge is that for those two examples you provided, there needs to be not only the provision of expertise, but somebody who feels like they're listening and can build rapport and trust so that somebody who has had a negative experience with a vaccine feels like they've been seen, they've been heard, and now they're ready to learn something. How might we societally empower those kinds of relationships? So this might be like partnering, right, with certain professions or professionals.
Well, again, I don't have an answer for you, and let me explain why. For example, today, the amount of mis and disinformation out there is so substantial that how do you as a healthcare provider, a pediatrician, a family practice doc, a nurse practitioner, a public health vaccinator, how do you address the challenges of that mis and disinformation when you're lucky if you have a 10-minute time window to visit with these patients because of today's healthcare system and the inefficiency and lack of adequate care that's there? So if you had all afternoon to sit down, go through the information thoughtfully, listening a lot, as you just pointed out, and then sharing a response, that doesn't happen. because the healthcare system we have today demands I see your 55 patients a day today. Okay? And so that's number one, is that we have a problem. Number two is we have a federal government that for the last 12 months has done nothing to promote vaccines as such. And so we even saw that this past winter, where here we are sitting in a pretty bad flu year, and yet we had almost 3 million less people vaccinated for flu against influenza by the time that the peak of cases had occurred in this country than last year, the year before, when we had an active campaign to promote vaccines, the influenza vaccine. So right now, basically, the public isn't seeing proactive messaging around vaccination. And of course, then what happens? They defer to the other message out there that says, wait a minute, these things can be dangerous. The final piece of it is, today, if I'm an individual, say 5 years younger, and I'm getting vaccinated, which means that's when you have the most likely encounter, think of all the other health challenges that occur in children. And there are many. Well, if I got vaccinated on a Wednesday, and then by chance alone, on Friday, something happens to me that has nothing to do with the vaccine, but in my mind it does, because now it happened 2 days after I vaccinated my child, that is a very hard situation to actually counter. I know of a physician who tells the story over and over again that they were seeing a child in clinic, a well-child visit, about to vaccinate the child. And the doctor got called away momentarily. And the time that they had walked away until they got back, the child had a febrile seizure. Actually, basically had a seizure in the office. But there had been no vaccination yet. It hadn't happened yet. Now, if that had time-wise occurred 15, 20, 30 minutes earlier, you know very well, everyone would have said, oh my God, look at the vaccine caused this. And so I don't want to diminish the possibility that there can be injury sometimes with vaccines. That would be foolish. But at the same time, many of the things that happen to kids just happen. The same thing is true with influenza vaccines in adults. If you look at the number of people who have heart attacks every year within the 72 hours after getting their influenza vaccine, it's very substantial. Why? Because that's where heart attacks occur, not because of the vaccine. If you look at people who didn't get vaccinated for a given age, they have exactly the same risk of those heart attacks as the person who got vaccinated. It's just because so many people have heart attacks in the 60, 70, 80-year-old age group, you're bound to have multiple events in a given community where someone had a heart attack within 3 days of getting vaccinated. Didn't mean there was anything about cause and effect. Those are all real challenges for us right now, to try to come back, do that very empathetic listening you're talking about, which I agree is very, very important, and then to be able to spend the time with that parent to be able to help them understand what does it mean to get the vaccine, what does it mean not to. What are the consequences if you get the vaccine from a potential health problem versus what are they if you don't get vaccinated and encounter that particular infectious agent in the community? So I think this is a huge area of work that we need to really dig into much more, and we're trying to do that right now so that we can be compassionate, honest, and thoughtful communicators of public health information.
What strikes me, using the epidemiological language here, microbiological language, is public health communicators have to mutate. Because the way they used to convey information was easier because they were trusted figures by virtue of the letters that they had after their names or the universities they were affiliated with. But it seems as though we've gone from, I've been in the field, in my case, for 40 years, in yours for 51 years. Eric, don't even say how many years, because it's so frustrating that it's a lower number than mine. But the point is, there's a lot of collective experience in this podcast. And it seems that today, it doesn't matter. What matters is popularity. And do you say something that makes me feel like you get me in a way that this intellectual professor, blah, 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 doesn't. So do you see a morphing, I'll use that word instead of mutating, do you see there being a need for public health systems, university systems, to morph in terms of how they deal with the communication of the information they are experts in? What would that look like?
Well, first of all, I think it's important to emphasize it's not necessarily about morphing, meaning these are some of the things that we should have thought about all along. One is humility. You know, you have to know what you know and what you don't know, and you have to be able to share that in a way to say, this is how I know what I know, and this is what I don't know, but this is what I'm going to do to try to find out the answers for you. And let me give you an example. In the very earliest days of the COVID vaccines becoming potentially available, meaning they were still just coming out of the studies showing this very impressive protection, I was involved with discussions about how do we present and represent this information. And, 95, 97% protection, but at 2 months following vaccination, okay? Well, if you know anything about coronaviruses, you know that they're historically notorious for mutating, for changing, okay? And that basically what you're encountering today with the coronavirus may not be exactly the virus you're going to encounter 6 months from now. And so I had suggested to no avail that the message should be to the public that these vaccines are 95 to 90% effective at preventing you from having serious illness, hospitalizations, or death in the first 2 months afterwards. But now that everybody in the study looking at these were vaccinated, so it was no longer, you had the vaccinees and you had your controls, people who are given an inert substance, not a vaccine. Everybody's vaccinated. But so let's start following on a monthly basis all the people in the study. And at that time, then report out on a monthly basis, now what's the level of protection? Now what's the level of protection? So if we suddenly saw at 3 months, we dropped down to 90%, and at 4 months, we're at 82%. We may very well hit a point by 6 or 7 months that says, boy, we need a booster. And everyone would have anticipated it and said it was something we considered all along. We might need a booster. That's not unusual for some infectious diseases. Look, we get a flu vaccine every year. And if we had done that, as opposed to telling people 95, 97% protective, take your mask off, you're fine. Okay? Only then in that summer of 2021 to be, oh my God, look what happened. We now have widespread transmission of previous vaccinees. People then said, you lied to us. You didn't tell us the truth. You told us we were okay. Yes. So it was something as simple as that. It was not a lie. They didn't intend to ever misrepresent the data, but what they did or how they set up to represent the data was not helpful in terms of the public's understanding of what these data meant. Mm-hmm. So think how you would have reacted at 8 to 10 months when you got your COVID after you had had 2 shots and said, wait a minute, I thought I was protected. Or you had been told, we're going to start seeing more cases likely. We're going to likely have to make a recommendation for an additional dose. How you would have taken that differently. So when you talk about morphing, it's not that we have to create a new set of standards. It's not we have to create a whole new agenda. We got to be much more thoughtful about the agenda that we have and how we present data. I did that early on in the pandemic. I wrote an op-ed piece in the Washington Post in early March of 2020 and said, whatever you do not do lockdowns. Do not do lockdowns. Why? Because number one, this is going to last for years. This isn't going to be for a couple of months. Are you really talking about preparedness to lock down for months and months and months? And what we have to do is prepare for how do we get through everyday life without the lockdown. On top of that, the lockdowns were in many ways really a joke. And I don't say that with humor, I say it as pain, because it turned out that in early March to mid-March of 2020, 41 different states initiated some form of lockdowns, trying to reduce transmission. So people meant well. It wasn't like they were trying to do anything, kind of nefarious. They meant well. But the problem is that how do they work? Well, in Minnesota, as an example, the governor issued a decree that basically said non-essential workers should stay home during this time with no end date on it, okay? But the problem was 82% of our workforce was deemed as essential. So, I mean, tell me, was that a lockdown? I mean, that's just crazy. But yet the public came away with that sense. By the end of May in 2020, every state but one had completely eliminated any more lockdown requirements, okay? Yet if you go back and listen to people talk about the pandemic, they'll say, oh, these government lockdowns lasted for years and ruined the economy. No, that wasn't true. There surely were some additional lockdowns as such, or limiting behavior, but it was because people were scared. People were frightened. They were doing their own. They wouldn't go out and eat at restaurants, not because they were told they couldn't necessarily, but they didn't want to. Sporting events changed. Concert events changed. And so there again, we misrepresented in many ways, not by intent. There was nothing intentional about what we should have expected. I was on Joe Rogan March 10th of 2020, very earliest days of the pandemic. And I, at that point, said, I believe that there could easily be 800,000 deaths in the next 3 years, okay? Mm-hmm. And we needed to prepare for it that way. Well, it turns out that, in fact, in 3 years, we had 790,000 deaths in the United States. Mm-hmm. I almost nailed it. Mm-hmm. Now, think if we had given that to people as something to think about. This isn't for the next 4 months. This isn't for the next 4 weeks. This is for a couple of years. How are we going to get through? The Chinese learned a very valuable and unfortunately tragic lesson when they had large segments of their population right early in the days of the pandemic go into true lockdown. People couldn't leave their house for not months and months. They have food and medicine brought to their homes, okay? So they did that. But they didn't vaccinate their population. And I wrote an op-ed piece in the New York Times predicting this several months before it happened, then it happened. They, because of social political pressure, finally released these lockdowns in China. And guess what? In the next 60 days, millions and millions of Chinese died from COVID. Had been fully protected by staying at home, but hadn't been vaccinated. Now, again, you didn't need to be the smartest kid in the school bus to anticipate these kinds of things. And so I think this is where we have to message much more clearly, what do we know and what do we not know? What can we anticipate with the pandemic? And that's with my book, The Big One, David, that's exactly what we tried to do in that book, was to lay out what should we have learned from the COVID pandemic. And in that process, how do we then apply that to get prepared for future pandemics? So I know that's a long-winded answer, but I hope it's helpful.
I'd love to interject for just a moment.
Go ahead. I'll swing back after. Go ahead.
There are two key takeaways that I took from your response there, Mike. The first was what you explicitly stated, which is humility. The second is pragmatism. And I want to just offer a few thoughts and then pass it back to you. On the pragmatism piece, it's very clear to me listening that, and this comes into our skill set as psychologists, is that if we're going to help people to buy into public health initiatives, we need to make it clear and tangible. So when you were talking about that early in the pandemic, the advocacy was actually, you don't need a lockdown. I would almost imagine, filming a video of you going to the grocery store and what do you do when you go to the grocery store? What mask are you wearing? What is your behavior? Like things to make the behavior more clear and tangible. Like maybe part of the problem, coming back to another thing you said, is we don't really have a way of taking the 95% efficacy or safety statistic of a vaccine and showing the public, what does that look like? Mm-hmm. They see the 3%, the 5% examples of the quote unquote failure because social media disseminates it, but they don't see what it looks like as a success. So this is an observation and a question back to you, is how might we make these examples more tangible for the public? And then the second piece on your humility, I bet you would not expect me to say this, but I'm actually reminded of a line by the rapper Nas in his most recent album, and believe it or not, it's actually a boast, where he says, "I know a little about a lot." And how can we help the public to know a little, know enough about a lot? You know, how, for example, you know, in grad school they taught us correlation does not equal causation. How can we teach that in a practical way for people so they can know a little about a lot? What are your thoughts about those two things?
Well, first of all, I wish I knew. Okay, again, you know, it's that honesty. You know, during the major days of the pandemic, we had 400 to 500,000 people a week listening to my podcast. And one of the things that I tried to share in that podcast is what did we know and what did we not know? Just that honesty. And that's what people wanted. In the case of the early days and not going into lockdown, I did a lot of work around respiratory protection and the fact, what could an N95 respirator do for you? Well, it could virtually give you almost 100% protection. So when I went to the grocery store, I wasn't at increased risk for contracting it because I had my N95 on. And so one of the things we needed to do was offer the kind of information that said, okay, this is how I can deal with this, but this is what you're going to deal with. And I think that we were far too afraid in many cases that we would upset or alienate the population by making some of these statements. You know, I looked at many physicians and I was shocked at how many of them didn't understand respiratory protection. And the fact that you needed N95. I mean, if you look at surgical masks, they provide almost no protection whatsoever, none, either from getting infected or being infected and sharing the virus with others. And that was something that was really difficult. I went to 4 different hospitals in the Twin Cities metropolitan area during the pandemic, where I walked in the front door and with my N95, fitted N95 on, and I was told I needed to take it off and put on a surgical mask because that's what they use there in that hospital. And I said, no way. and each of the 4 instances, I kept my N95 on. And, you know, if we had hospitals doing that, you know, think how much work we needed to do to educate the public. And we messed up badly on respiratory protection. The World Health Organization took almost 2 years before they finally got their act together in terms of understanding and promoting the science of respiratory protection. So I think again, it starts out with humility. Just be humble and knowing what you know and what you don't know. You know, when I did the estimate of how many people I thought were going to die from the pandemic in the first 3 years, I actually at that point was in a situation where you know, I basically laid out the numbers, how I came upon them. Okay, simple deduction. No black box. No, A plus B plus C plus miracle. None of that. Okay, and that's what people wanted to know. How did you know what you said? How did you come about that? And I think that to me is again the key message here is just be honest and tell people what you know and how you know it, and do it in a way. I jokingly say I come from a small rural Iowa farm town. And there was a major restaurant in town on Main Street where at 10 o'clock on every weekday, all the business people kind of come and have coffee. And it's called the S&D Cafe. And I've always said, if I can't sell something to the crowd at the S&D Cafe at 10 o'clock on a given morning within 10 minutes, I need to go back and redo my message. That's, I think, what really was a very important part of being more successful. It was, in fact, knowing your audience, knowing what the message should say, and then knowing how to deliver it so it says that.
So I want to pick up on that, and I'll start by saying I think, Mike, you did a fantastic job of conveying this in the big one. For those who haven't read it yet, in the beginning of the chapters is this unfolding thought experiment that demonstrates how a what is it called? The first case, the
index case.
The index case multiplies planes ferrying people around the country within hours, and then very quickly there is a news conference with experts from around the world talking to reporters. What I thought was, from a writing perspective, absolutely fantastic, is I viscerally felt the fear spreading through the journalists. I could almost hear, what about, and I was saying, okay, and I could just hear this rapid fire peppering of experts. So I would say there's a three-legged stool here: pragmatism, as Eric said, humility, as you said, and the third is knowing that in the presence of fear, where people suddenly feel we're safe, and then in the next minute, we may not be. What if we all catch this? Like I remember the fear when Ebola was spreading. We thought, my God, it'll take the whole world down. People are going to be bleeding out in front of us, right? So the way you conveyed the escalation of fear, the demand for answers, definitive answers, when we don't yet know, I thought was a beautiful literary description of the bind. So I really like what you're saying, that we have to know what we know what we don't know, convey it in a humble way, and be willing to face the fear and say, excellent question. We don't have an answer yet. Here's what we're doing. Am I capturing, in a sense, what you were trying to convey?
No, thank you. You did a wonderful job. That's exactly it. And, I think the challenge with it is it's such a simple concept in many ways. It's kind of one of those things like, wait a minute, you went to graduate school for all those years to know just that? And I think that the message is that, in fact, if it isn't simple, and we say that the KISS principle often in public health, keep it simple, stupid. And I think that that's really, to me, one of the most important messages, is that if you're going to go in and try to blow them over with facts and figures and diagrams and big words and long sentences, you've already missed the mark. Relate to them where they're at. And I think that's really an important point.
Yeah, I agree.
Kissing at the S&D Cafe.
There you go. Yeah, you'll have to come visit. It's a pretty famous place.
Yeah, that's really wonderful. So I think it's worth emphasizing, sort of collecting together, synthesizing what we've talked about the last few minutes. At the end of the day, this conversation may sound like it's about microorganisms and esteemed scholars and physicians in the world of epidemiology. But in a sense, I don't think that's what we're talking about. We hang together as a community by fairly thin threads, and they can either be strengthened or they can be torn. So in the last number of years, not just because of COVID, but for all sorts of reasons, those threads seem to have been cut, so that we're, as you say, circling many wagons, but then shooting against one another. From a public health perspective, do you have any perspective on what public health can do to convey information about what binds us rather than what divides us? Are there certain...
Yeah. Well, I think, David, the very first thing is what I call situational awareness. You got to know what the hell's going on. And I think that we are in a period right now where, with childhood vaccines in particular, at such risk because of the current administration's mis and disinformation. And in fact, I have a piece that's being published today that talks about how much that mis and disinformation is even sometimes more damaging to protecting children's lives than are many of the lies and misinformation out there. It's because people don't realize the accumulation of these. Well, I don't know. These vaccines might kill you. I mean, here's Secretary Kennedy when he was at the funeral of one of the measles cases that died in Texas. He was asked the question, should these kids have gotten measles vaccine? Well, obviously he was in a very difficult spot because he said they should probably get the vaccine, but remember, we don't know what's in those vaccines. Well, come on. That negated the whole entire statement. The thing that people remember, we don't know what's in those vaccines.
Yeah.
And so that accumulates over time. And we have to know and better handle how to address that. And so that's one of the things our group at the Vaccine Integrity Project, which is part of CIDRAP, is also working on right now. We're trying to provide the kind of information that the advisory community immunization practices, which all were fired, replaced with anti-vaccine zealots. That is, in fact, what we're trying to really guard against, and helping the public understand, no, these are the facts. This is what it is. And again, just as I've done all my career, just called balls and strikes, that's why I had the opportunity to be in every administration since Ronald Reagan, because I wasn't seen as a Republican or a Democrat or a partisan. I was just seen as a public health private in the Army of public health. And I think that's what we need more of, is that whole ability just to say, as Eric's not old enough to remember this, David, you will, the old Dragnet program, and Joe Friday would come to the door and ask a question. This woman would start off with a long answer. She said, just the facts, ma'am, just the facts.
That's great. That's wonderful. Well, Eric, are you humbled enough to be able to say, I'm not that young, I know a thing or two?
Well, I was laughing because the second you said Dragnet, my thoughts went to just the facts, ma'am. But I'm thinking, oh, maybe this is a cultural reference I'm not going to be familiar with. But and I can even hear the intonation of the statement.
Yeah, good. You make an old timer like me feel younger with that statement. Thank you. Thank you. Now this is about human relations, right there. If you can make an old guy like me feel better, thank you.
Well, actually, I'm really glad that you said that. That, in a way, that speaks to the magic that's happening in this interview, which is that we find ways to relate to one another. The three of us are doing it right now, and maybe that's a way that we help, the privates in the public health army connect to the public and help them see that, they have something that can be trusted.
Yeah.
Right? These entry points.
I think the other thing is also finding points of consensus and not throwing those out. For example, I have spent a good part of my career very concerned about dual-use research of concern. This kind of research where you may actually make an infectious agent more infectious or more capable of killing for a study, but if it ever gets out, look what happened. And there's been this ongoing debate about what happened in China, in Wuhan. Was this a lab leak, or was this, in fact, a natural spillover? Well, I can say I've looked at this issue very, very closely. I've been involved with reviews of it. No, we're not going to know. We are never going to know. Okay? It's just, you can't make up out of something or out of whole cloth later on. Why is that important? Because we're not getting ready for the future, because we are so fixated on that debate of the past. We can't get by it. Well, we need to come to consensus and say, okay, you don't agree with me, I don't agree with you, we're going to accept that. But what can we together do to get us better prepared for the future? And let that become the roadblock to that. And I think that's very similar to the point you're making here, is that how do we bring people together? How do we come with that? We don't have to agree on everything to make big changes that can make the world a safer place. And if we're going to allow ourselves to be red or blue, if we're going to allow ourselves to be a lab leak versus an animal spillover, we're not going to go anywhere. We're going to keep shooting the wagons at each other, and that's, to me, that would be the tragedy.
Well, I'm thinking that's a perfect segue into this idea of a common foe. I want to say common foe rather than common enemy. That's too militaristic. But one of the things that I think challenges you in your field is the common foe here is essentially invisible to the naked eye. Right? We walk around. What do you mean, just breathing, I'm at risk? There's nothing in the air. Oh, maybe today's foggy. Maybe today's cold or whatever. So I think about what happened going back to 9/11, when on the rubble of the towers President Bush, with tears, was talking about what he talked about then, and it brought the country together regardless of their differences. Do you see a way in which greater appreciation of what the common foe of epidemiologists is, to convey that in a way that has all of us sensing we are our brother and sister's keeper? We have to protect each other. Do you see a way of getting there from here?
You know, David, this is going to border on an area that I have very personal feelings about, but little expertise.
Okay.
Look at how messed up the world is right now.
Yeah.
Look at the whole issue of what alliances mean or what relationships mean. What can you trust and not trust? Here I sit in Minneapolis today at the height of what's happening in our community, which is tragic. It's just tragic. I never thought I would see this. And so one of the challenges we have is how do we bring the community together when they're already consumed by all these other issues? And so, you know, it's kind of the hierarchy of need kind of thing, Maslow's hierarchy. Right now, people just need to get through day to day to day with all that's happening in the world. And so from that perspective, I think it's important to understand your question is right on the mark. It's exactly what we ought to be asking. It's exactly what we ought to be answering. And the fact that we are so consumed right now with all these other issues, it just means we're not dealing with it. I mean, I'm watching measles come back in this country in a way that I could never have imagined it would happen. And it's going to get much, much worse over the next several years. And that's an immediacy issue now. So preparing for a pandemic, I will put that off to another day. Okay. You know, and I think that's the challenge we have right now is how do we judge today's actions versus tomorrow's actions versus next year's actions in terms of priority.
One of the things that I think links what Eric and I do to what you just said, in our last episode with Renee DeResta, we were talking about how to get to a point where we can have some sort of resistance to and triumph over misinformation and disinformation. One of the things she said is that it becomes much easier to convey information when we're looking at each other face to face. So paradoxically, part of what I think we're coming to, and we'll have to finish our conversation shortly, is the need to move from isolated cells into collective spaces where we can share our differences, talk about our passion around those differences, and yet see some things that bind us together like a common foe that we all need to be better prepared for whenever that day comes. So I think that's a tall order, but I think that's the marching order that we're facing. What are your maybe closing thoughts here, Mike?
Yeah, I think this has been a wonderful conversation. I thank you for it. I think it highlights the fact that not all answers for what we need to do are going to come from the science itself, but it's going to come from the exploration of personal relationships. It's going to come from, you know, people such as yourselves who bring a very different expertise to the table, one that you don't often think about in this setting, but it's a critical one, okay? So I think to me that is the message I take away today, and I thank you very much for covering this issue here, and hope that from that perspective that you know is helpful to people to understand where we're at and what we can do.
And we thank you for, you know, bringing your expertise, but delivering it in a way that's really relatable. I think that's something we're all really agreeing on, is that that's going to be the way that we reach people. Yeah. And we really appreciate your joining us.
Well, thank you. Just remember, it's all about the S&D Cafe.
Okay. Excellent.
Thanks, everybody.
Take care, Mike. Thank you.
Bye-bye. Thank you. Bye-bye.
He is a wonderfully informed, but also accessible person. I really appreciated his presence with us, his openness with us about some really, really difficult topics. What do you think?
Yeah, you know, I first thing I found him very emotionally relatable, which in some respects surprised me because I'm not necessarily expecting that from, somebody who's outside of the psychotherapy world. He's kind of coming to it from public health, but I found that, Michael was very emotionally accessible. And there were kind of two parts of our interview that really stood out there as examples of that. So I think one was, frankly, the pained way that he was talking about, hey, I've served in every administration from Nixon through Biden, including Trump 1. And I'm outside here like the rest of you, just beating on the door saying, hey, like we got to do something. And just, I could really hear his anguish about that. And then I think the second thing that just was very powerful was he used the metaphor later in the interview when he talked about meet me at the S&D cafe, in his hometown. And it was just such a great, he was relaying what it's like to go there, but just also relating the fact that, when people show up in that cafe in that town, they're just people. They're not tribes. They're not warring camps. They're not polarized, individuals or groups. They're just people in a town, meeting for a cup of coffee, having a lunch. And there was something that was just really relatable about that. What were your thoughts, David?
Picking up on exactly that theme, what I felt was that Meet Me at the S&D Cafe is also a really important story about one of the ways that this country has derailed. That was a story about people talking to people. There was nothing there that was about, I don't trust those elites. I don't trust the messaging of the elites. They have a hidden agenda. No, this is, can you pass me that sugar? Are you done with the sugar? Right? Do you have any syrup? I want to put it on my stack of pancakes. It's such a human, humble, open way of relating. And if we can't talk at that level, we're at risk. The other big thing that I felt he really helped me appreciate, both in what he said and also in the book of his that I read, is that in his role, he is this close to terror, right? That there are viruses and other contagions that are always forming. Thank goodness the vast majority of them fail to gain traction, but sometimes they do. And as history has shown, tens of millions of people can be at stake. So
That's right.
to appreciate what it actually means to be on that front line, on the one hand, because we're dealing with microorganisms that don't have an agenda other than to survive. And sometimes in that effort to survive, we die by the millions.
Yeah.
On the one hand. And on the other hand, to feel as if what he's trying to get out there to protect, it's being thrown back in his face. He's being dismissed. What that must have been like. And he talked about that a little bit when he said we needed to do a better job of messaging.
And what an emotional burden to have a knowledge about something that you're the messenger, you're the canary in the coal mine, you're trying to tell people, and you use the word terror, that this pathogen could kill millions of people.
Right.
And yet there's indifference or ignorance, and you're trying to fight through that. I mean, what a burden to carry that knowledge.
I also felt, as sort of a student, an amateur student of history, in situations where one of these viruses gains traction, one of these microorganisms gains traction, sadly, it's only a short time before some group gets identified as the cause, and then we turn on that outgroup. And I see that happening in the country today. We turn against China because it must have been deliberate. They tried to bring America down. Or you hear about it in other ways where there's always some outgroup that gets identified as the cause, rather than saying, we're all in this together. Can we join hands and go forward and figure out how to get on top of this?
Yeah.
Yeah.
I mean, the debate about the origins, right? Was it a lab leak? Did it happen at this marketplace? I really think psychologically what it is people saying, I'm really uncomfortable with not knowing.
With not knowing. Yeah.
Yeah.
Yeah. That's a really important point, Eric, and he addressed that in our interview, where he said there are things that we just don't know. I shared in the interview the part of his book where he makes up an imagined press conference, and the journalists are desperate to be able to get information to pass on to the public, and he, as the public health official, desperate to give you information. If I say we don't know yet, am I invalidating myself? If I give information that I do know but it's not enough, am I invalidating myself? You can see the conflict in not knowing, right? That's such a human reality that we are so uncomfortable with uncertainty.
Yeah.
Right? Yeah. So you'll hear, I think as you listen to it, I hope Eric and I have captured some of the highlights of what Dr. Osterholm shared with us. As always, let us know your thoughts, like, subscribe, and follow.
The current email address is transformingpodcast@gmail.com.
Thank you, co-hosts. This is that other co-host who can't seem to get the name straight, David Alter. Until next time, take care, everyone. As always, thank you so much for tuning in. We look forward to catching up with you again in our next episode. A quick reminder, while we are both doctors of psychology, this podcast is not a substitute for professional medical advice, does not offer diagnoses, or engage you in actual treatment. The conversations, the opinions of our guests, and any information that we share here are meant for your general knowledge, your learning, your inspiration, and your motivation to put some of our ideas into practice in your day-to-day life. Remember that everybody's body and everybody's personal health journey is different, so what works for one person may not be right for the next or for you. If you have questions about your health, any psychological or medical condition, or any changes that you're thinking about making to your lifestyle, your diet, your exercise routine, your medications, or some other aspect of your life, it's always best to talk with a qualified healthcare professional who knows your personal history. Never ignore or delay professional advice because of something you heard here with us. We want you to enjoy the show and to walk away with useful insights, but ultimately, you are responsible for your own health decisions. Please use your best judgment, stay curious, and always listen to your body. Take care, be well,